frequently winds up on the test. Okay?
So is that your subtle hint saying that this slide is going to be a test question?
Well, it's just kind of, I'm not as good with the review. I'm not as pointed with my review, but I will tell you, as I go through my lectures, I tend to try and tell you ahead of time, you know, I'll say a lot, one of my favorite statements is, this is not where I would spend my time. Okay, that means that, is it eligible for a test question? Yes, but it's probably going to be one. So that's not where you should send the bulk of your study time. So I do try to at least keep that separated out for you, where you should spend the bulk of your time. And if I haven't at the end of a lecture, or you want me to clarify that at the end of any given lecture, speak up and I will be glad to do it. But I prefer to do it while I'm lecturing up front instead of coming back and reviewing more on the back end. I tend to try and keep that and pattern that in as I'm lecturing, okay? Please, I'm always open for questions, okay? One of the things you have to know about a CBC is, what is a properly collected specimen? Well, since over half of you are in phlebotomy graduates, and has everyone taken either the practice class or is there anyone who did not take a phlebotomy class? You two did not, okay. So, you're smart, education. Ask everybody else. And if everybody else doesn't remember, come see me, we have to talk. How to properly collect a CBC. It's going to be in an EDTA whole blood. What color is that? It has to be minimum half full. Okay, and we have to be, and you don't want it over full either. That's a nursing trick. Our tubes only draw this much, and the tube was filled to the top, and I called them rejected. Well, I gave you plenty. You sure did. Okay, a properly collected microcontainer is acceptable. No clots. Avoid extremes of temperature during transport. Please do not leave it in the car in the middle of summer and then bring it in and ask me to run it. It won't work. No clots or fibrin strands. This mostly affects the platelet count. And my favorite story, not one I did, but one of the people I used to work with said she called up to a doctor, said the specimen had to be redrawn because it was clotted. He says, it's not clotted, I took the clot out myself. You also took out, you know, a couple million red cells, all of the platelets. You know, a good bunch of them white cells probably got hooked up in there too. So, you know, one of my favorite statements to nurses is, do you want an answer or the right answer? My most recent analogy that I came up with works really good. Would you hand a chef a plate of rotten food and ask them to give you a good meal? If you give me a rotten specimen, I'm not going to give you good results. Okay. A lot more of that is hemolysis, you know, because we put it in the hemolyzer when we get it down in the lab. And we're told, don't let that sit and clot. Why do you always let those sit in the lab and clot? How do we keep them from clotting?
Mix them.
Invert it. Mix it. As soon as you get it out, mix it properly right away. If you mix it, it won't be clotted. They have found EDTA tubes 10 years later in evidence lockers that were not clotted. They were gross and nasty, but they weren't clotted. Okay, clotting occurs at draw time. And we have a really hard time explaining to phlebotomists and to nurses and to anybody else who's drawing blood. It won't clot. I can let it sit here for a week. It won't clot if it's properly held. Most hemolysis is okay. What is hemolysis? The burst of red blood cells. How do I tell if the specimen's hemolyzed? Spin it down, and what color is the plasma? Red. The plasma is going to be red if it's hemolyzed. Okay. We don't spin down CBCs, right? Truthfully, unless it is so grossly hemolyzed that when you spin it down, you cannot tell the difference between the plasma and the cells, your CBC is going to be fine. Okay? You have to hemolyze over half of the red cells before it really affects your H&H. Okay, so grossly hemolyzed specimens, not a problem for us. And how will you tell? your H&H won't match. Okay, that's how you're going to tell if the hemolysis has affected it. Your H&H won't match. Okay, where do I recommend you spend your study time, especially this week? Right here. Every week on my test is going to be a case study, a scenario, whatever you want to call it. A good 20 points out of almost every test, and some more than that, is simply telling me, is it high, or is it low, or is it normal? Other than the indices, which sometimes I have a hard time using values without those winding up on the border, okay? Other than the indices, I'm not going to give you, okay, if a normal female red count is 4.00 to 5.00, I'm not going to give you 3.99, okay? Or if I do, then you can either tell me it's low or normal, and I'm going to accept both of them. Because something that you need to know about reference ranges, they're reference ranges. So ask me what a normal white count is. Well, do you want the value that's out of the book we're using now, the value out of the MA book we were using, the value out of the book we were using before, the value out of the book that I studied from when I was in school? Do you want the Celdine ranges, the Coulter ranges, the Sysmex ranges? Do you want the ranges for here or for Belleville or for... They vary a little from place to place. So what's a normal range for a white count? 5 to 10. I'm not going to worry about it till it's under 3, and up to 15, it's probably not really significant. Okay, so, oh, they've got a 3 white count. Probably got a viral infection. They've got a 1.1 white count. Ooh, uh-oh. Labor patient with a 20 white count. Well, she's probably under some stress there. Labor patient with a 35 white count. Uh-oh. So you understand, it's not about numbers. It's more about understanding where the ranges are. So every test will have a CBC on it that you're going to mark what's high, what's low, what's normal. Okay. Will the computer tell you that when you're out in the field? Of course. And what happens when the computer goes down? Or the computer screws up? Or somebody types the new normal range into the computer incorrectly? Not that anybody would ever do that, but you know, for a while protimes of 140 were just fine because somebody forgot the dust. Whoops. Okay, so it behooves you to keep up with what's going on and not just let the computer do all your thinking for you. So if you let the computer do all your thinking for you, who are they going to hire? They're going to hire a computer. Okay. Yes.
So when you're telling us that we're going to have ranges, are we going to have a range from newborn to male? Or
No, thank you. Excellent question. You need to know adult female and male, and that's it. The newborn and 12-month-old or the newborn and baby ranges are there just to give you an idea of what happens to those ranges as we start dealing with pediatric patients. Okay? A newborn that came down with a white count of 30, I'm not that worried about them. They've been under some stress. Okay? I'm not going to worry about a newborn with a white count of 10 or 11. Certainly is perfectly fine. And really a newborn, the white count, unless it's really up in the 30s and 40s, till we get a specimen a little bit later, it's not going to be that significant to us. If I've got a newborn who comes down with a hemoglobin of 19 or 20, it's fine. If I've got an adult with a hemoglobin of 19 or 20, somebody needs a big tall glass of water. Yes?
Does the Sysmex or other analyzers auto-correct for the age of the patient with the reference range?
Absolutely. That is the one nice thing that the computers do, is that the patient's age is matched up, age and sex is matched up for all of the normal ranges. Okay. On the test, you will not, but on the test, I won't be giving you the normal ranges. I had a student suggested that. You want me, you want me to give you the answers down here so you can look and compare. If you can't look and tell me if 9 is between 5 and 13, we got bigger problems. Okay. So no, you need to know the ranges. Okay? And we'll talk more about that in just a moment. This is all of the normal ranges. These here match when you get your syllabus. There's a page in here, it's got a little doctor guy on the top of it. I just like him, he's cute. Okay, these ranges, match these ranges. These are the ranges I'm going to be going by, okay? So if you find a reference, because I know y'all are gonna Google stuff, so if you find a reference that has a different number, these are the ranges I'm going by, okay? I am going to zing through these next few slides pretty quickly. We'll do these all in lab. We are going to add today the white count, the manual white count. Are you going to be doing manual red counts and white counts in the lab? In fact, it's my best April Fool's Day joke ever, was I pulled out all the hemocytometers and Unipets and had microhematocrit things sitting around and told everybody we were going to have to do all manual work for the day. I was working with two really gullible people who started doing the QC. It was all I could do to keep from passing out laughing. We didn't even have a spec. We couldn't even do a hemoglobin. There's no way we'd ever do manual anything. If it doesn't work, we're going to be shipping it somewhere else. Okay. You will, however, be doing body fluids. Okay. And so this is going to give you some really good background, and they still do body fluids manually in a lot of places. All right, so it also gives you an idea of when I'm talking about a 2 white count. Oh yeah, I remember I had a 2 white count and there was like only like 1 cell on the whole hemocytometer, you know. And so if I know that the patient's supposed to have a 2 white count and I counted 27 cells, obviously something's wrong somewhere. Okay, either Diane typed a 2 instead of 12, which happens, or I misplated, which happens more often. Instead of a 1, what's our dilution on a red count? Anybody remember? What's the dilution on a red count? You said it.
9 to
What's the dilution?
the
final dilution.
1 to 10, so
1 to 9.
1 to 200. You've got it. You put 10 microliters with 1990, which gives me a 1 to 200 dilution. Okay? Because we have, back on our normal ranges, we have millions of red cells. We have thousands of white cells. Okay, so I make a lower dilution for my white cell. I make a 1 to 100, and I'm going to use, we're going to use acetic acid, a 2% acetic acid solution. We want the cells to hemolyze. That is the first step in doing a white count. Smash all them little red cells. Pop them babies so you're not counting them. Okay? If you put a white count on and there are cells everywhere, you used the wrong thing. Go get the acetic acid instead of the saline. Okay? Not that any of my students would ever do such a thing. Well, you're all going to find you're going to make mistakes and I'm going to know right what it is. Well, it's because somebody else has already done it and it was probably me. Okay. We're going to count the 4 large corner squares. When we do the red count, if you remember, we count the 4 corner and center square of the center square. When we do the white count, we're going to count all 4 of these large outer squares. Okay? We're going to count 4 square millimeters. And your counts are going to be more like 8, 12, 27, not 150 billion, okay? You're not going to have counts, and if you have a white count in the hundreds, call me over right away to look at it, and we'll figure out what you did wrong. Okay. We just, you know, I'm not going to bring those for when we're doing manual white counts. That's even more cruel than I would ever be. Okay. You need to know how to use this equation. I don't know how Jean taught you to calculate. How did Jean teach you to calculate a red count when you were in 150? You went through this equation? Okay, good, good. The reason we want you to get used to using this equation, even though the numbers are the same over and over and over, when you hit body fluids in the fall, if you're already used to using this thing and not confused by this thing, it's going to make your life a lot easier. You're going to be really stressed this fall. And this is one less thing that you have to stress about. All we're going to do is put the average number per side, multiply by the dilution, and divide by the area times the depth. In the white count, if we calculate it out, it's the number times 250. Okay, I would rather you learn to use this. It will help you more later on. Okay, can I stop you from doing this? No. Will I know if you do this? No. Will I care if you do this? No. Will it be easier for you later if you do this? Okay. The answer is expressed to 1 decimal place. The unit, and units are very important, and Jean stressed this when she talked about different things. Units are important. Okay. It's 10 to the third, or thousandths, per millimeter cubed. The SI unit, I think, is 10 to the 9th per liter. It comes out to be the same thing. Okay. But white counts are traditionally reported to 1 decimal point. Manual red count, you've already done it. Do a 1 to 200 dilution, plate on a hematometer, count the appropriate squares, throw it into your calculation. Yeah, if you do the calculation out, you multiply by 10,000. Or of course, you can always do the method that I tell the medical assisting students that I would teach. You take the average and take your pen and put a decimal point after the first number. Ta-da! They need all help. They're not going into lab. They just need to have a dumb background to get it. I do not know why your textbook switched to 1 decimal place on red counts. As far as I know, 90% of the places, at least around here, still report them to 2. Okay, so please do report your red counts to 2 decimal points. And Jean has agreed she's going to go back to the other next fall, but she noticed the textbook had changed and was trying to stay with the textbook. But I think we're going to stay with what you're actually going to see in the lab. Most of your analyzers report them out to 2 decimal places. And the unit is millions per millimeter cubed. Platelet count. You can say thank you, Diane, right now because we're not going to do any of these. The reason being, nobody does these anymore. All of the analyzers have a secondary platelet count. Nobody does these. And even Memorial, and believe me, we do stuff that nobody else does or has done for a decade. So we used to do them. We probably will plate 1, do it together on the front scope just so that you've seen one. But basically, you remember when you're counting red cells, you know those little tiny kind of fuzzies that are between the red cells? Those are the platelets, and you're counting fuzzies. And you have to determine whether it's actually a refractile platelet or whether it's just a fuzzy or whether it's red cell stroma. I had students who could get 5 red counts in 6 tries. I had students who could get the 5 white counts that I required in maybe 10 tries. I had students who tried 15 times and couldn't get 1 platelet count. They just are very, very difficult to do. This stuff may still be on the boards, so we're going to talk about it. Like I said, we'll probably do 1 just so that you've seen 1, but I think our time is better spent elsewhere. How to calculate them out, same thing. We have a 1 to 100 dilution. Then we count 1, we count the entire center square, so it comes out to multiply by 1,000. They can be expressed either as 3 digits times 10 to the 3rd per millimeter cubed, or there are still a lot of places that for some reason actually report them out fully. You know, so like a 2 platelet count would be 2,000. And they would actually report out 2,000 per millimeter cubed. I don't know, whatever you wind up with where you go, it's all the same thing, okay? But a lot of textbooks, a lot of reference material, a lot of articles that you might read as you get further out, you'll find platelets are sometimes expressed without the exponent. Okay, so if you're reading a study on TTP or something, and they talk about a 235,000 platelet count, they're not talking about 235,000 times 10 to the 3rd. You know, they're talking about just straight. It's the only reason I mentioned that. I'll be reporting them out this way. You've already done hemocytometer counts, simple, basic stuff, okay? You will need to know how to do the calculations. I'm gonna have to calculate some white counts and red counts on the test. Okay, simple, straightforward. Yes, you can use calculators. God, yes, you can use calculators. Lord knows I can't do it without a calculator. Questions on how to use the hemocytometer, pretty much basic stuff that you learn. Don't overflow it, make sure there's no bubbles. Make sure you're counting the right area. Make sure it's not drying out. That's another one. If your counts start going up, probably too slow and it's starting to dry out. So count faster. Sources of error. This is something you're going to be responsible for. If you read the general objectives in the course, in the syllabus, I have two big ones that don't really seem like much, but for every disease state, you need to know how you get it, how you treat it, how you diagnose it, what tests, etc. And for every test, you need to know how you do it, what reagents are used, any calculations that are involved, and sources of error is something you need to understand for any test method you're doing. Sources of error shouldn't be just in class. When you hit the real world, you need to understand sources of error. You know, why am I getting that? Why is my hematocrit 11 and my hemoglobin's 9? Be able to figure out what's going on. So technical dilution, pretty much if I ask a question on this, other than the calculations, it's going to be pretty self-evident. Okay, a little common sense will probably answer that one. Okay. Hemoglobin determination, I talk about this one because I know there was a test question on it once. When you go in, have your blood drawn, you stick your finger, drop it in some blue stuff. The blue stuff is copper sulfate, and it's a known concentration, so if your hemoglobin is high enough, it'll sink. If it's not high enough, it'll float. And if it floats, they go spin it down to do an actual crit. Okay. As the solution gets older and older, stuff floats more and more because it got junked down the bottom. Okay. This is not valid for, although they do take something like this when they're screening like in Haiti or something like that, because you can carry copper sulfate with you very easily, and you can get water and make your solution. Hemoglobin determination, you all did that, right? Spec. Remember using the spec? Mm-hmm. One thing we're going to make sure of, I will zero it every day, but make sure you do blanket every time you run it. Okay. We'll be doing those. And it says, use a cuvette, optically accurate glass tube. Yeah, we use 13 by 100 tubes. Cuvettes are expensive. Spectrophotometry, I'm not going to go much into this. I'm not going to be asking you questions about this necessarily on the test. Cyan, that hemoglobin's read at 540. That might be fair game. I don't honestly remember if it's on there, and I don't know if it'll go on there or not. Beer's Law, the only reason I mentioned it, and Barb will get into this in chemistry, big time. Chemistry's all hers. The only thing I remember about Beer's Law is it's more stuff, less light. So if you got more stuff in the cuvette, less light's going to come through. All right? And the way my one former student came up with this one, and I stole it happily. The way she remembered it was that the more stuff, the more beer she has, the less bright she is too. So that's how she remembered it was Beer's Law. Barb can handle all that. Okay. Standard curve, we are going to set up a new standard curve for our hemoglobins. Originally I was going to do it today. I think today we're pretty much going to have time for phlebotomy, and I want to show you guys how to run the instruments. I think that's pretty much all we're going to do in lab today. I'm very flexible. If you guys are not ready for your RBC practical on Thursday after we're done tomorrow, you all just let me know and we'll postpone it, okay? We will have a test every Tuesday morning over whatever we got through the week before. And I have
set like every Tuesday?
Every Tuesday,
okay.
8 o'clock, in your seat, there'll be a test.
All right.
Just a done deal, okay? It will be over whatever I got. I've taught this class for 6 or 7 years, and honestly, I've never gotten through the exact same amount of material every week, which is why I have to rewrite my tests every year. Okay, so it's whatever we went over. And I will send out a statement Thursday evening telling you exactly what things we went over and exactly what things will be on that next test. Okay? We are going to set up a standard curve in lab tomorrow, and Jean had you do it on paper, okay, which I think is a wonderful thing to have learned, because again, it's just a visual, helps you when you're talking about standardization curves on an instrument, which, you know, you don't really realize what they are. However, I'm going to bring this into the 20th century. We're going to do them on Excel. So you'll have a nice handy dandy little chart. There will be no more. For one thing, she's really good at drawing that line. I screwed up every time. So we're going to let Excel do mine for me. Okay. It's a good thing for you to see multiple ways to do it. But no, remembering the little curve that's a line on a piece of paper, it is helpful when you're trying to learn about standardizing and stuff like that. Okay. So we will work with that tomorrow. Cyan met hemoglobin. That's our Drabkins reagent. We have it in the little white bottles. What I want you each to do is get a little white bottle and put it in your spot. And in fact, as if each person wants their own little white bottle, go right ahead. We can open new ones when they run out, or sometimes after you leave. But the one thing we are going to really make sure of, and I think Jean started it in COAG, is when you open something, what do you have to do?
Label it.
Label it, date, time, initial. Time, if it has a time expiration, in other words, if it's got 6 hours or 12 hours, you're going to put the time on it. If it just has a number of days, I want your date and the initials. Okay. Hemoglobin method, these are some inherent sources of error. Again, a lot of this is just kind of common sense. One of the things that we do want to look at, though, is our sample abnormalities that interfere with H&Hs. She probably talked about the pipette, the not wiping the tip, not blanking the speck, you know, messing up technique. We also are going to have some things that are going to be wrong with our patients that are going to affect our H&H as well. We just talked about Beer's Law, which says what? More stuff, less lye. Does it say more hemoglobin? What's it say? It says more stuff. What is a lipemic specimen? Fat in the blood. What does it look like when you spin it down? Looks like milk. I have pictures of one that is hemolyzed. I have one that looks like a vanilla milkshake, strawberry milkshake, and chocolate milkshake. Yeah. But yes, it looks like fat. And in fact, as I've actually seen them so bad that when you turn them upside down, it slimes down the side. It doesn't run down the side. Yes.
What turned it around?
Icteric bilirubin. Okay. So lipemia is stuff. This is one of the most common things. In fact, it's the question that I ask on the test repeatedly, is what is, if I have a MCHC of greater than 36, what is the most likely cause? I keep getting one or two who still tell me spherocytes. The most likely cause? We have 1 in 5 million people. Oh, I think they may have a class in here. We have 1 in 5 million people who have spherocytosis. About 1 in 100 of us has lipemia. Let me go see if they've got a class. They want to see the time it is. People are looking. Nope, bring me out there. Okay. It always takes a week or two for me to figure out who's where. Okay. Icteric is an increase in bilirubin that comes with liver disease. We're not going to talk a ton about it, but it is one to remember. It will still be measured at 540 nanometers and can cause an interference in our hemoglobin. And we'll talk later about how we fix or what we do to take care of those. Hematocrits, you've done microhematocrits so many times, you should be able to do them in your sleep. No big hairy deal. Technical, one question that I do want you to think about, a lot of times when I put things on the test, it won't be as strictly the patient's, and you know, here's the patient's red count, hemoglobin, hematocrit, here's their indice. Why do you have 104 MCV? Okay, So the choices might be things like, it wasn't centrifuged enough. Okay, so I may ask you to actually, like, don't get scared, but think. Okay? So some things may be a combination. You may have to pull pieces from everything. And actually one of the students who just took the board said the same thing. He says, well, they didn't ask questions like you did. They're just, one thing at a time. It's like you had to know this and this and this and this and this and this and put it all together to be able to answer that. Well, the answer is if you can put it all together to answer that, they're not going to ask you any more questions on that subject. They're going to move on to something else. All right. Relationship of the hemoglobin and hematocrit. The hemoglobin times 3 should equal the hematocrit plus or minus 3. Can almost guarantee there will be at least one question on the test that says if your hematocrit's 15, what should your hemoglobin be? What would the answer be?
12 days.
Well, I'm getting all kinds of answers.
What was that again?
Okay, if my hemoglobin, because I had the example of 10 up here. So if my hemoglobin's 10, 3 times 10 is 30. That's why 10's up here, is because I can do that in my head. And 30 minus 3 is 27, and 30 plus 3 is 33. So if my hemoglobin was 15, what should my hematocrit be? A little bit.
42,
42 to 48. Okay. 15 times 3 is 45. Subtract 3, add 3. Okay. Now that really only holds for patients who are normal. Okay. One of the causes of your H&H not matching can be patients with abnormal red cells. Okay. But for a general reminder, and the nice thing is this works well as a QC monitor. Because every patient who goes through the analyzer is going to get an MCHC, which compares our hemoglobin and hematocrit, right? Say yes. Okay? The hemoglobin and hematocrit get compared. So if I start having a lot of patients where the indices are out, it may be an early indicator that my instrument's screwing up. If all of a sudden, if I take a group of 100 patients and run them through my analyzer, and my indices, these are my normal ranges for my indices, okay? If I watch those indices, do we have XB? Oh, okay, we'll get to that in a minute. We'll back up, okay? The RBC indices, these are how you calculate them, yes? Know how to do that, they'll be on test. Okay, see, it's a gimme, you've already done. The RDW is the only one that we're going to add in here. That's the red cell distribution width. That one, you aren't going to calculate. That one is going to be interpolated from under the histogram on the red cell on the RBC channel. In other words, where are you going to get it? The analyzer is going to tell you. Okay? There's a lovely formula. If you want to know how to calculate it, go right in your book and figure it out and take a look at it. And if that makes you all happy, you just go right ahead. How am I going to get it? The analyzer is going to spit it out and tell me. Okay? All this is going to tell us is a measure in the variation of cell size. The reason we tack this one on, what are all of these? What does the word mean? What does that refer to?
Average.
Average, right. Average. These are average, okay? If I look around this room and I say, what is the average height? Okay? We come up with what, 5'8", 5'9" is usually what an average height comes up to be, okay? What is the average height at the lab I work at? The average height's probably 5'10". But we've got Eric and John, and then we've got me and Nancy. You should put things where the average person can reach them. Not up on the top shelf. Not down on the bottom shelf all the time, okay? Average. So if I just say the average height's 5'10", you're going to walk into the lab expecting to see everybody 5'10", right? No. I got big ones, I got little ones, they average. If I've got big ones and I've got little ones, they're going to average. But my RDW is going to be high. It's going to tell me that my average may be normal, but I've got some funky things to look at. Okay? that they're not all uniform, which in our red cells is what we want. We want nice, uniform, fairly close little soldiers, okay? I'm not going through the calculations. If you don't understand them, please ask me. Sources of error, well, duh, if you put the wrong numbers in. You didn't set it up properly, and believe me, I invert MCH and MCHC upside down at least half the time. Forgetting to use whether you use a 10 or 100 as the corrector. How do you know whether to use 10 or 100 as the corrector? Which ones use 10? MCV and MCH. And what does MCHC use? What? One of my students came up with this. You know how she remembers? She counts the C's, and that's how many zeros you use. So the MCV and the MCH have 1 0, or have 1 C, so they get 1 0. The MCHC has 2 C's, so it gets 2 zeros. I'm all about stupid mnemonic devices, and believe me, they get dumber as the semester goes along. Okay? And fat fingers on the calculator. If you don't put the right numbers in the calculator, it doesn't give you out the right numbers. Indices is quality control. I promise we're almost finished. And to me, this is one of the most boring ones. Indices is quality control. In any given population, the average MCV, MCH, and MCHC will remain constant. And all CBC analyzers use this, whether they call it moving averages or they have all kinds of different wonderful names for it, but it's basically the same thing. In a moving average, the average of each index is calculated for each batch of 20 specimens. Okay, so I run 20 specimens through. I take the MCV from each of those specimens, add them together, divide by 20, that gives me an average. I plot that point. I take the next 20 specimens, I take the MCV for each specimen, add them together, get the average, plot that point. I do that for 20 batches. 20 batches of 20, when I take and average those 20 batches of 20 together, my MCV or MCH should hit my target. If it doesn't, there's a lot of things that could be wrong, but it indicates that I'll give you 2 choices here. Everybody has to vote. Do you think that if the moving average is out, does it give me a indicator of an accurate or imprecise? So raise your hand if you think that moving averages that are out indicate an accuracy problem. Raise your hand if you think moving averages that are out indicate a precision problem. Okay, we're going to try this again because everybody didn't vote. When we vote in class, you all got to vote. No apathy here, okay? So, who votes for accuracy? Who votes for precision? Okay, we got pretty much unanimous precision. Exactly, our precision. But in an analyzer, precision often goes out long before we see truly inaccurate results. So this is going to give us a free, because really it's just a calculation, right? And how much does it cost for a computer to do a calculation? Nothing. Okay? So this is a free way to constantly monitor our machine. So as I'm running all day long, this is constantly monitoring my machine. If these go out, it's going to give you a flag. It's going to say you've got some kind of problem. Now what you do have to watch, if I have a whole group of babies that comes down in the morning, and I ran a whole group of babies MCVs tend to run around 105. Is that going to skew my average? Yeah, so if it tells me stuff's out, I'm going to go, oh yeah, I had all those babies. Okay. I had the iron deficiency clinic today, and all of those tend to be very small cells. So my MCV goes out, I go, oh yeah, I ran all those. You know, I ran all those sickle cell patients through, or sickle cell clinic, or whatever. Okay? All right, last thing we're going to talk about, this is new this year that I added because several students said that I put case studies on all the tests, but they weren't quite sure what I wanted them to do. So we're going to try and talk you through some of these. I am going to kind of reconfigure how I do my case studies. It used to be I gave you very general questions on the test and very specific questions when I assigned them at the end of the year. I think I'm going to swap it so that I'm going to say, you know, would this, would this patient, you know, I'll be more specific on my test questions. Honestly, what is the disease state and those kind of things, those last questions after the case study, little points. So if you don't know it, don't go, oh my God, I'm going to flip the test. Nah, I don't make those worth a ton of points. It's just to get you thinking. Okay, yes?
On your test, do you have it all Scantron or do you have short answer?
And I have to do Scantron.
All?
Oh, no, I have some short answer.
Okay.
Yeah, I used to grade them just on the test, but I hate Scantron. Okay. For each case study, step 1, read the patient history. If somebody comes in with a low hemoglobin and their history says gunshot wound, and I had that, I put that on a test last year, and half of the class missed it. They're giving me all these wonderful hemolytic anemias, and he's got a gaping hole in his body. Okay? Read the patient history. There's a lot of information in that. In fact, there was a recent article about 2 years ago that came out that said that medical schools are going back to making sure doctors know how to take a good history. Because, you know, we had a guy who had a bleeding time of over 20 minutes. Like at the end of 20 minutes, we're pushing, trying to get the dang thing to stop. We finally found out, we asked, did you take aspirin? Well, yeah. Well, how much do you take? Well, I'll take a couple in the morning, but sometimes I forget if I took it, so I'll take some more. He was taking 3 bottles of 325 milligram aspirin a week. That question never got answered because no one specifically asked what over-the-counter medications he was taking. Oops. You want to put that guy on the table and cut him open?
No.
Okay. Step 2, identify out-of-range results. That's where I said the normal range. This is where the bulk of the points on those questions come in. So I'm talking 20 easy points. Very easy points, okay? Step 3, answer the questions to the best of your ability. Figure out why you answered as you did. And as the course progresses, the case will get harder. But if you give me a reasonable answer, even if it's not the right answer, I will give you credit as long as you can support your answer. So don't just throw something down, put it down and why you think that, okay? I'll give you credit for the thinking, even if it's not the answer I wanted. I may take a point off because it's wrong, it's not the correct answer, but I may give you 5 points because you had good thinking behind it, okay? The goal is to get you looking at patient results critically. Are these results reasonable? I worked in a lab where we would occasionally get horses from the local track. A horse's MCV is 50. The first time that comes up, the teachers never tell you when they do that to you. So they can watch your face when you go, oh, the MCV is 45. It's a horse. Or run chicken blood. All those cells are nucleated. Counts them all as red, as whites. If results are suspicion, what action should you take? Why do I want you to learn how to do this? This is what you're gonna be doing. At least this is what you should be doing as a tech. Okay, not just pushing the button. All right, last slide. We're gonna do one sample case study here real quick. We've got Mary Smith, age 57, she's a Caucasian. She presented in the ER complaining of weakness. She has a history of DVT. What's DVT?
Diverticulitis.
Okay. I take a quick look at her results. Her white count, we've got the normal ranges over here for you. Those won't be on the test. We've got the normal ranges over here. What are her outstanding characteristics do you see?
Red hemoglobin.
HCT.
Red.
She's anemic, right. Her red cells are all low. Okay. Indices are pretty normal. Everything else is pretty normal. Diff is boring. Okay. Always look at the other lab results. I did this last year. Oh my God, the students freaked out. What do you mean? You put a proton and a PTT on here? Yeah, what did you just get out of? What class did you just finish? Should you know what the normal, is that a normal proton?
No.
No. What do you think is wrong with this lady? Too much Coumadin. Exactly. Exactly. and we do have a class coming in, so. So basically, that's how I want you to do a case study. Those are what are gonna be on my test. And pretty much in that format, except they won't have the normal ranges in there. We're gonna go, I want you, why don't we, it's been a long morning. Why don't we take a good 20-minute break? Okay, be back in the lab by 1:15.
Do you want these back now or the lab?
Oh, bring them to the lab with you. If you want to just sign them, she's gone over them, I assume, with you before. The rules in my class haven't changed from the rules in Jean's class. So if you have any questions about the syllabus, please feel free to see me. Otherwise, sign it and turn it into the lab. I'm going to take our goodies with us.
Oh, I guess, yeah.
No, I guess I didn't go for it. She moving up, she's thinking it's fine. For me this year.
I think the headphones. I got a couple more steps. Okay, good.
Were you really?
I know last time I ended up having two here because I didn't take it away the first time.
They must have. They left mine on the
Sure, yeah, I'm
little
pretty
booth.
sure they.
Right before we took our exam, she made us get them, put them in a bag, and put our.
Yeah, I didn't do that.
I didn't do that.
Oh.
I did.
Like, I didn't do that. It's kind of like, because I know like we were supposed to end up doing that last time. I didn't do it either, and I had two up here with my
these
name.
are probably other people's.
Well, there's no name tags on them. So I don't know.
This fit.
On any of them? Did she say she wanted us to have it now?
No, we're not even.
Yeah.
Are you always going to do that?
I'm going to say yes, as long as you all get through everything you're supposed to. If I start seeing that it's too much, then I'm going to. If I start seeing yellow, then
You want us to grab a lab coat?
yes, you are going to.
I guess this is so we don't have name tags.
I'm kind of hoping to find stuff here. So I got a cup here.
Yeah, that'd be fine. Just put them on there. Yeah, come see if you can find your name tag here. Tiana, you seem popular. You're in here a couple times. Dig through if you can find your own grade. If not, steal one. And
So I was like, I know that's Amanda's handwriting. I'm sure that's a different Amanda because I don't recognize that handwriting. So that's not mine.
Oh, is that?
No, it's not.
in case you guys guys have not figured it out, this room has two temperatures. Honestly, between the semester one in hoodies and two pair of gloves trying to do it was so cold you don't be bloody. It was miserably cold. Just because it's summer. There's a whole bag of them up here. They're clean.